Pathophysiology. In carotid atherosclerosis, progressive accumulation of lipids and inflammatory cells in the intima of the affected arteries, combined with hypertrophy of arterial smooth muscle cells, results in plaque formation. Eventually, shear stress may result in plaque rupture, collagen exposure, platelet aggregation, and clot formation. The clot can remain in the vessel, causing local occlusion, or travel distally as an embolism, eventually lodging downstream in a cerebral vessel. In the case of cardiogenic embolism, stasis of blood in the atria or ventricles of the heart leads to the formation of local clots that can become dislodged and travel directly through the aorta to the cerebral circulation. The final result of both thrombus formation and embolism is an arterial occlusion, decreasing cerebral blood flow and causing ischemia distal to the occlusion. 13. Normal cerebral blood flow averages 50 ml/100 per minute, and this is maintained over a wide range of blood pressures, mean arterial pressures of 50 to 150 mmHg, by a process called cerebral autoregulation. Cerebral blood vessels dilate and constrict in response to changes in blood pressure, but this process can be impaired by atherosclerosis and acute injury, such as stroke. When local cerebral blood flow decreases below 20 ml/100 per minute, ischemia ensues, and when further reductions below 12 ml/100 per minute persist, irreversible damage to the brain occurs, and this is called infarction. Tissue that is ischemic but maintains membrane integrity is referred to as the ischemic penumbra because it usually surrounds the infarct core. This penumbra is potentially salvageable through therapeutic intervention. Reduction in the provision of nutrients to the ischemic cell eventually leads to depletion of the high-energy phosphates, for example, adenosine triphosphate, ATP, necessary for the maintenance of membrane integrity. Subsequently, extracellular potassium accumulates at the same time that sodium and water are sequestered intracellularly, leading to cell swelling and eventual lysis. Electrolyte imbalance also leads to depolarization of the cell and influx of calcium into the cell. The increase in intracellular calcium results in the activation of lipases, proteases, and endonucleases, and the release of free fatty acids from membrane phospholipids. The depolarization of the neuron leads to the release of excitatory amino acids, such as glutamate and aspartate, that perpetuate the neuronal damage when released in excess. The accumulation of free fatty acids, including arachidonic acid, results in the formation of prostaglandins, leukotrienes, and free radicals. In ischemia, the magnitude of free radical production overwhelms normal scavenging systems, leaving these reactive molecules to attack cell membranes and contribute to the mounting intracellular acidosis. All these events occur within 2 to 3 hours of the onset of ischemia and contribute to the ultimate cell death. 13 later targets for intervention in the pathophysiologic process involved after cerebral ischemia include the influx of activated inflammatory cells, starting from 2 hours after the onset of ischemia and lasting for several days. Also, the initiation of apoptosis or programmed cell death is thought to occur many hours after the acute insult and can interfere with recovery and repair of brain tissue. Hemorrhagic stroke. The pathophysiology of hemorrhagic stroke is not as well studied as that of ischemic stroke. However, it is known that the presence of blood in the brain parenchyma causes damage to the surrounding tissue through the mechanical effect it produces, mass effect, and the neurotoxicity of the blood components and their degradation products. 5. Approximately 30% of intracerebral hemorrhages continue to enlarge over the first 24 hours, most within 4 hours, and clot volume is the most important predictor of outcome, regardless of location. 15 hemorrhage volumes, 60 ml, are associated with 71% to 93% mortality at 30 days. 5. 6. Much of the early mortality of hemorrhagic stroke, up to 50% at 30 days, is caused by the abrupt increase in intracranial pressure that can lead to herniation and death. 1. There is also evidence to support that both early and late edema contributes to worsened outcome after intracerebral hemorrhage.